A very good evening, everyone. So, the first abstract that I'm presenting is Pregnancy After Breast Cancer, a systematic review and meta analysis. Author of this study is Matteo Lamborghini, and this paper was published in Journal of Clinical Oncology. Very few women conceive following treatment completion for breast cancer, and there are concerns persisting among patients as well as physicians about the potential detrimental effects of pregnancy after breast cancer in terms of reproductive outcomes as well as maternal safety. So, this systematic review and meta analysis aimed at providing updated evidence on these topics. So this is a Prisma flowchart. We're all familiar with what a Prisma is for meta-analysis. The first step is identification of records. It was done through the database as well as other sources. Then the duplicate records were removed and the records were screened. Eligibility was ensured by keeping in mind the three endpoints of the analysis: the likelihood of pregnancy after breast cancer, reproductive outcomes, and maternal safety. This was followed by inclusion of the studies which were updated, and the overlapping studies were excluded, and ultimately 39 studies were included in this quantitative synthesis. So I would just want to highlight what all points were considered as a measure of reproductive capability. First was the likelihood of pregnancy, comparison between the proportion of patients who had a pregnancy after prior history of breast cancer versus the population of healthy women, versus the proportion of survivors who had a pregnancy after prior history of other malignancies expressed as relative risks. Reproductive outcomes in patients with prior history of breast cancer versus those in the healthy women from general population in terms of pregnancy completion, abortions, low birth weight, IUDs, for gestational age, congenital abnormalities, emergency C-sections, and the postpartum hemorrhage. Maternal safety was measured by comparing the survival outcome between the breast cancer patients with or without a subsequent pregnancy in terms of the DFS and the OS. Pooled relative risk, odd ratio, and hazard ratios with 95% confidence intervals were calculated using random effects models. So of the 6,462 records that were identified, ultimately 112,840 patients with breast cancer, of whom 7,505 had a pregnancy after diagnosis, were included. The rest were the general population. The breast cancer survivors were significantly less likely to have a subsequent pregnancy as compared with the general population. The relative risk was 0.40. The risk of cesarean section, low birth weight, preterm birth, small for gestational age, these risks were significantly higher in the breast cancer survivors, particularly those with previous chemotherapy exposure as compared to the general population. But there was no significant increase in the risk of congenital abnormality or any other reproductive complications. Compared to the patients with breast cancer without subsequent pregnancy, those with a pregnancy had actually better DFS and OS. Similar results were obtained after correcting for potential confounders and irrespective of patient, tumor, and treatment characteristics, pregnancy outcome, and the timing of pregnancy. So these findings provide definitely very crucial information for improving the oncofertility counseling of patients with breast cancer, guiding them and their treating physicians in making evidence-based decision on future. It's a well-known fact that patients as well as physicians have concerns with the potential negative impact of previous breast cancer diagnosis and treatment on the reproductive outcomes. These highly relevant issues have been dispelled by the present meta-analysis, and the safety of pregnancy after breast cancer was shown irrespective of the tumor characteristics, including among women with hormone receptor positive disease with nodal involvement, previous treatment, pregnancy outcome, timing of pregnancy after breast cancer, and the BRCA status. So, if we look at the entire patient population that was looked into, the hormone receptor positive population was in minority, but there was no significant effect on these outcomes depending on the hormone receptor status. Also, it was seen that the median length of hormonal treatment prior to conception for these patients was around 50 to 60 months. So, take home message from my side is that these results provide reassuring evidence on the safety of conceiving in breast cancer survivors. Patients' pregnancy desire should be considered a crucial component of survivorship care plan, and proper and timely referral of these patients who are interested in future conception to fertility units is extremely crucial. Strengthening onco-fertility programs and overcoming the barriers for their implementation should be considered a priority to improve patients' care and survivorship. So the next paper that I am presenting is Association of Germline BRCA Pathogenic Variants with Diminished Ovarian Reserve, a meta-analysis of individual patient level data. First author of this study is Volkan Turan, and the study was published in the Journal of Clinical Oncology. The key objective of the study was to determine whether germline BRCA pathogenic variants are associated with a decreased ovarian reserve. An individual patient level data meta-analysis was performed using 5 data sets on 828 evaluable women who were tested for germline BRCA. Out of these, 250 carried the germline BRCA mutation, while 578 were negative and they served as controls. Of the women with germline BRCA, 4 centers studied those affected with breast cancer and 1 studied the unaffected individuals. So the data was adjusted for the center, age, body mass index, smoking, OCP use before the final analysis, and the AMH levels in affected women were drawn before the systemic therapy. Mean age of women with versus without germline BRCA, as well as with germline BRCA 1 versus germline BRCA 2 was similar, around 33 to 34 years. After adjustment, women with germline BRCA 1 2 had significantly lower AMH levels as compared to the controls. When the adjusted analysis was limited to affected women, the difference persisted. It was around 25% lower, and the serum AMH levels were lower in patients with germline BRCA 1 but not germline BRCA 2 compared with the controls. So these were the factors that were the confounding factors which were taken into consideration, which affect both the ovarian reserve as well as the serum AMH levels. So this is by far the first multi-center analysis and the largest study investigating the relationship between germline BRCA and AMH levels in women with or at risk of breast cancer. BRCA 1, 2, as we all know, are the members of the ataxia telangiectasia mutated, ATM mutated mediated DNA double strand break repair pathway. And inadequate repair of the DNA double strand breaks result in severe mutagenesis leading to carcinogenesis and tissue aging. The basic research in mice has shown that germline BRCA 1 but not germline BRCA 2 mutant mice have fewer primordial follicles that accumulate more DNA double-stranded breaks in the oocyte with age compared with the wild-type mice. So for the affected women with germline BRCA, their already lower ovarian reserve status is compounded by larger chemotherapy-induced loss, resulting them highly liable for infertility. BRCA1 has actually more complex involvement of the ATM mediated DNA double strand break repair pathway than BRCA2. BRCA1 actually has a role in the homologous recombination repair as well as the checkpoint regulation through the check2, while BRCA2, the role is limited to the homologous recombination only, and that could be one reason why it is specifically affecting the ovarian reserve. It's also possible that the differences which are reported here are underestimations, because we do consider that some severely affected individuals might have undergone an early risk reducing salpingo-oophorectomy surgery or have developed breast and ovarian cancer treatment associated menopause and have lost their ability, have lost their reproductive function iatrogenetically. Unfortunately, the authors were not able to obtain data from 7 out of 12 studies that were identified. But the 5 studies that have been included in this meta-analysis represents 80% of all published data in terms of number. So definitely this analysis is robust for the relationship between germline BRCA and ovarian reserve in women who develop breast cancer. So the take-home message from my side is that young women with germline BRCA pathogenic variants, particularly those affected with germline BRCA1, have lower serum AMH levels compared with controls. They may need to be preferentially counseled about the possibility of shortened reproductive lifespan because of the diminished ovarian reserve. Thank you so much.